All right, ladies and gentlemen, welcome to the UCLA BrainSPORT Podcast, and I've got Dr. McGough, psychiatrist and head of the UCLA ADHD Center. How are you today?
I'm doing great. It's great to be here.
Thanks so much for joining me. Today we're going to talk about ADHD, and I think that it's important because ADHD really can affect brain functioning significantly, right? And ADHD can get a lot worse after a brain injury or after a concussion. We know that. So I think understanding ADHD, the intricacies of ADHD goes a long way, not only for, understanding how to optimize our brain function, our brain health, but then also what we can do to treat it in the context of it getting worse after brain injury. Would you agree with that?
All right, let's roll.
Let's do it. Yeah. So a couple of other things that I wanted to talk about are just real quick to just demonstrate the significance of ADHD. An ADHD diagnosis puts you at risk for a lot of different things. And I just want to start by just listing a couple of different things, and then you can add or you can say, hey, that's not right, because you are the expert. But ADHD increases the risk for obesity, diabetes, hypertension, sleep problems, immune disorders, metabolic disorders. It gives you an increased risk of low quality of life substance use disorders, accidental injuries, so traumatic brain injuries, educational underachievement, unemployment, gambling, teenage pregnancy, difficulty socializing, delinquency, suicide, and premature death.
It sounds like you read my book.
Yeah, so I think a good place to start would be, is it ADD or ADHD?
So they've changed the names. When the American Psychiatric Association wants to sell more books, they change a name and then they sell more books. But the formal name now is Attention Deficit Hyperactivity Disorder. It leads to some confusion because you don't necessarily have to be hyperactive, but that still is the overarching label of what we call this. It's actually the most common behavioral problem amongst kids. It affects about 1 out of 10 kids anywhere you go in the world. And about half those kids still have difficulty as adults. Yeah. So that's, it's very common. It's mostly genetic. It's about 70% due to genes. So it's actually about as heritable as height. And, tall parents have tall kids, short parents, short kids, and kids, ADHD kids often have parents or other relatives who have the same condition.
Yeah, I've seen it described in two different ways. I've seen it described as a neurodevelopmental disorder, right? So I'm thinking in the context of someone that has ADHD as an adult. If they're diagnosed with that as an adult, then does that mean, if it's a neurodevelopmental disorder, does that mean they had it when they were children, they just weren't diagnosed with it, and then now for whatever reason it's become an issue as an adult? I've also seen it described as a mental disorder, right?
I think, my preference would be to describe this as a neurodevelopmental disorder, which in the case of an adult, and this I think might inform some of our chat about the effects of concussions, basically, if you think of this as you have a set of genes that create risk for this, and then depending early in life, with the various interactions you have with your environment, it manifests the syndrome, the symptoms that we call ADHD. And really by definition, most kids who are hyperactive are evidencing that by about age 4. Sometimes the attention deficits show up later. But what this really means, particularly if you're trying to decide if someone is having these cognitive issues or impulsivity issues because of, say, a trauma or concussion, a brain injury, did this exist before that event occurred? Mm-hmm. That's a key thing. Because indeed, I think an adult with ADHD as a true neurodevelopmental disorder will have evidence of this going back to grade school.
Got it. Okay. And then, so you talked about the manifestation of different symptoms of ADHD. How is that diagnosis made? It seems like it's a pretty subjective criteria, right?
Well, I was thinking actually coming over today, when I was in medical school about 30 years ago, there were a couple of conditions. Lupus was one, where we diagnosed it by having 8 of 14 symptoms. Right. And then I think I was a second-year student, and they came up with a blood test. Yeah. And suddenly they had, we understand what this is. Well, we're not there in psychiatry. We know that there are a lot of circuits not quite working properly in the brain that manifests these symptoms. The main symptoms really are, an inability to stay focused, easily distracted, problems organizing, problems managing your time, and really being restless and impulsive. But other things can do that too. In fact, one of our first insights into this was with the brain injuries that occurred with World War I, where people came back having war trauma and they kind of exhibited this. Or even the flu epidemic of 1917, which we hear so much about these days. There were sequelae to that a lot of people whose brains were impacted by the infection had these problems with focus and restlessness. But ADHD goes back. And again, it's primarily, while again, sometimes there are people, they're born at 28 weeks or other things happen that cause this. Primarily, it's a genetically driven, familial, inherited risk that then you manifest as you grow up.
Yeah. So, I think, what do you think about the argument that, so the diagnosis of ADHD, from what I was reading, it has to be made in different, the symptoms being exhibited have to be made in different contexts, right? Meaning that not only do they have to be exhibiting symptoms of inattention or overactivity at home, but then they also have to be exhibiting those symptoms at school.
Right. So the idea basically is if this is a disorder of brain function or a extreme type of brain dysfunction, you're going to see it in multiple settings. Now, people have different strengths and weaknesses. Families have different strengths. Kids who are smarter, kids who have more intact families, kids who have resources, they often can get by, or they're going to really expensive private schools and the teachers aren't going to say anything bad about them. I mean, so sometimes the picture is distorted, but a trained clinician will know how to basically cast a wide net, get information from a wide variety of sources. And for kids, typically what you see are problems at home, problems at school, and then social difficulties. Older people, you may not see such global impairments. I think people with ADHD who are successful, they get into areas of life that they're better suited. So, if you're 5'3", you're probably not going to play on Duke's basketball team. Right. But if you can get into that area of life where you're well suited, great. But when there's a disconnect between the demands of your life and your problems with focus or impulse control, then there are ongoing issues.
Right. Unless you're a sharpshooter.
Well,
Duke has a history of sharpshooters, so you might be able to be 5'3" and a sharpshooter if you're shooting from half court. Anyways,
that could be true. That's all right.
But you're a Duke man, so you might be a little bit biased.
I am a Blue Devil, yes.
Yeah. So, in regards to this sort of like school-based feedback for the diagnosis of ADHD in children, what do you think about the argument that, hey, you're basically taking kids that have a certain personality type and you're placing them in a really structured and regimented environment that might not be conducive to their personality type or their sort of brain functioning, right? So they get sort of placed into this must be ADHD because, they're not excelling or they're, acting a certain way in this really regimented context that isn't encouraging some of those personality traits, but rather they're butting up against them.
I would probably come at it a little differently. I wouldn't view this so much as a personality, as a personality issue. Are you headstrong? Are you sensitive? I don't think it's like that. But the key thing that you touch on is you really need to be showing symptoms of inattention or restlessness that are that exceed what's expected developmentally for your level. So honestly, a third grade teacher who sees kids all day long and has his class of 30 kids is going to know the kid that isn't sitting still or is inattentive or disruptive to a degree that's just not typical. And that's really what you're trying to tap. Right. Everybody has some of this stuff at some times, but it's the kid or the person who has it really more times than not, and there are clear impairments related to that. So it's the developmental test compared to other people at your chronological level. Like, what are you showing?
Yeah, makes sense. Now, let me push back a little bit against that. So what do you think about a teacher that is spread way too thin, right? What do you think about a kid is very hyperactive, not really interested in what he's learning, and the teachers spread very thin, right? So, and then let's say in the home, right? Let's say he has like a lot of brothers, and the home life isn't very stable, right? So to a very stressed parent, they're coming to you, they're saying, hey, he's not paying attention to me, and he's very active, and he just won't sit still. I wonder if the interpretation of children's activities at home and at school are also influenced by the resources at that school or the home life, right? So much so that they get assigned, a diagnosis of ADHD.
Well, sure, and I think the, this is why you shouldn't diagnose your own kid by reading a checklist on the web.
Right.
You basically, a well-trained or a skilled clinician ought to be able to appreciate that there are biases. Yeah. Some teachers just want to get rid of the kid, and you deal with this, put the kid on medicine and get rid of him, or some teachers just don't believe in this and they don't want to. So you have to just, again, it's important to look very globally, get your information from a wide variety of sources. Sometimes actually your own interactions with a kid can be helpful. When I have kids literally jumping around my office, that's an indication. Right. But one-on-one, they can be fine. Yeah. So the other aspect, though, is if there is an impairment, you don't have a need for treatment. So I think what's also important to the clinician, in spite of what the checklists say, is, are there clinically significant consequences to this? Does the kid lose his friends? Right. Does a smart kid not do well in school? Is a kid going down to the principal all the time? Does a mom have to quit her job because the kid's been booted out of preschool? I mean, those are the things that one should consider before really, moving forward on this.
Yeah, great point. Now, you talked about the prevalence of ADHD. I think 1 out of 10 kids is what you mentioned.
About that,
ADHD's been around for a while. Actually, the first time it was described was in 1775 by Dr. Melchior Weikart. I'm sorry if I butchered that. He's a German physician. I'm sorry, Dr. Weikart. But he actually wrote the first textbook description of ADHD, which is interesting. But that leads me to my next point, which it's ADHD in 1997 in U.S. children and adolescents was about 6.1%. This is from a JAMA study, and then that increased to 10.2% in 2015, in 2016. Why is that increase happening? In a 8-9 year period, and I don't even know what the numbers are now. I wonder if they're even higher than that, but. Why would you say that that's actually happening?
Well, I think there is a little disagreement about this. I would probably take the view that it's more an ascertainment issue than a true change in the prevalence. As I said, this is really rooted in genetics. If you use the same criteria, you go anywhere in the globe, any population, it's kind of the same. But I think what's happened is society's acceptance of this and appreciation of it as a medical issue has really just influenced recognition. In the 60s, the idea was this was kids acting out bad parenting. Yeah. Even in the 90s, even within the field of medicine, there was a lot of pushback on this. There was one right-wing commentator in the 90s said this was a feminist conspiracy to turn boys to girls. Just a lot of, just stigma and kind of failure to admit this. But I think we've done a good job in terms of really having this seen. I think this podcast is a great, opportunity as well. This is rooted in the brain. Right. We have imaging studies. We have longitudinal studies. We have genetic studies. And it all points to the same thing. Yeah. So this is actually of the most biologically driven psychiatric disorders. But I interpret that increase more as just increased recognition, not that it's YouTube. Right.
Do you think that there might be an overcorrection at this point?
Well, there may be, and one of the problems we still have, unfortunately, is families with resources, families who, the kid's got a 5.3 high school GPA, but he's determined to go to some Ivy League school. They know how to work the system. Yeah. I think if you go to the west side of Los Angeles, you see much greater rates of diagnosis. Some of that is access to care. But I think, under-resourced populations, we know that it's clinically underdiagnosed in blacks and Latinos, and I think that really is just it's really more the tragedy of the system not meeting their needs.
Right.
So there is some bias in that regard.
I want to get your take. I was scrolling Instagram, and it's you know how the ads as you scroll. I don't know if you're on Instagram, but
yeah, but I don't look at the ads.
You don't look at the. I mean, you're smarter than me then.
I'm older than you.
Right. So, and I came across an ad about that. There was a remote service where you could fill out a checklist regarding ADHD, right? And you could receive, it seemed like to me that you could actually receive a diagnosis remotely of ADHD and then receive ADHD medication remotely. And I guess that would imply filling out that checklist, meeting with someone over telehealth, and then, if you meet the criteria. What do you think about that?
Oh, I wouldn't think it's the optimal way to do this. Again, I think there is, of course, it's like this. I mean, people are doing this for all sorts of things now. Everybody's an expert. I think it does take somewhat of a seasoned clinician who knows what this looks like. And it's not just going through the 18 symptoms. I mean, there's sort of soft signs, I guess, as a neurologist. You can appreciate soft signs. Yeah. But, you're talking to a kid and they've broken their collarbone 3 times, right. Or they crashed on the motorcycle, or they have that scar under their chin. These little things that don't give you the diagnosis, but they make you feel like, this is the story here. Yeah. I think it's actually dangerous for people to self-diagnose, but there is a problem with access to services. Yeah,
that's true. Now, speaking of social media, an interesting study came out of UCLA, actually, Dr. Steve Lee. I think he has like the UCLA ADHD lab.
Yeah, he's up in psychology.
Yeah. He found that he followed adolescents without ADHD at baseline, and he followed them for 2 years, and he found a significant association between higher frequency of digital media use and subsequent symptoms of ADHD. What does the role of the phone, social media, play into ADHD or similar symptoms?
So the issue, kind of a simple way to look at this, it's not that these folk don't pay attention. It's that their attention is really inappropriately focused. So ideally, you have to focus on the signal. The brain is being told this is important, you got to pay attention, but you've also got to monitor your background. And your brain ought to know how to switch back and forth between what you're supposed to be looking at and, again, just paying attention around you. So, you're rushing to your gate at the airport, you're late, you're trying to get to gate 42, somebody calls out your name from across the busy terminal. You somehow weirdly hear that, or you're at a party, same kind of thing. Right. Kids with ADHD, if they're playing a video game, I think the dopamine surge is so strong, they don't hear anything. Yeah. I'll ask him, well, does he have trouble listening? Well, if he's playing a video game, he can focus on that. So that's really the issue, is people with ADHD, it's kind of like they're drawn to the quick and easy. They're drawn to the rush, and they can really get sucked in. There's a whole other talk we could have about social media use. The red flag level is about 2 hours a day, but kids with ADHD really get drawn into it, and in particular, so I don't know.
I've heard like 9 hours a day
is acceptable.
No. I've heard
that doesn't surprise me.
Kids with ADHD will be on it for like 10, 12 hours a day.
Right, but again, I think we get the effect and the cause confused. For kids, people your age, it wasn't MTV that did this to your classmates. It was their genetics, but they get drawn into this other stuff.
Right, yeah. So let's move to the causes of ADHD. And like you really drove it home earlier and you kind of hit on it, where it's like it's predominantly genetic, right? I think I was looking at some studies and to demonstrate the genetic component, family studies indicate a risk to first-degree relatives of 4 to 5-fold the population rate or higher, with prevalence rates around 20% among first-degree relatives of people with ADHD.
Yeah, I think was that one of our papers? So UCLA,
I don't know. It was Cambridge, actually. I don't
UCLA 20 years ago, we were at the very forefront of this.
Yeah.
And I was part of a group of international investigators, where originally we thought it was going to be a simple gene thing, like your brown eyes, or something like that. Yeah. It's so much more complicated than that. And where we are now is there are at least a dozen areas in the genome that give incremental risk to ADHD. But interestingly, and they have to do with brain scaffolding proteins and all sorts of things like that, but they're the same risk genes for autism and schizophrenia and bipolar disorder. So it is not simple at all. But it is clearly rooted in genetics.
So are you implying that there might be a spectrum involved between ADHD, autism, and some of these other psychological disorders? Or do you think that there's just sort of this similar psychological component, genetic issue?
There's a, again, whatever combination of cards you have in your deck really does seem to influence this. And we see many people on the autism spectrum, also a spectrum, have ADHD symptoms, and a lot of ADHD individuals who one might suspect are a little bit on the autism spectrum. So there's definitely a lot of mixing here.
Yeah, great point. An interesting thing that I found regarding the genetic component of ADHD is that they actually found genetic variants within or near dopamine receptor genes, and it actually provided some pretty consistent findings that were supported through meta-analysis, which basically when you group a bunch of these studies together and you look at the validity of it, which is interesting, right? And we can talk about why that's interesting when we talk about sort of the underlying maybe neurobiology of actually what's going on. But do you actually find that there might be something there regarding the dopamine receptors?
Well, it's interesting, but it's not really right. So that's actually where we started. I mean, it's a little circuitous, but it's like, well, our medicines work on dopamine. Maybe there's some aberration in dopamine signaling, so let's look at the dopamine receptor. Those were our earliest studies. The problem is the incremental risk that is given by that is so small, it's not meaningful. So it's like, maybe if you look at 50,000 people with ADHD, there's a little bit of a signal, but there's a lot more going on. It's much more fundamental than that.
Got it. And let me push back a little bit on just the fact that it's like predominantly genetic, because I came across an interesting study of Romanian adoptees. Are you familiar with this?
I'm familiar with the Romanian adoptees, yes.
I'm sure you are. So, and correct me if I'm wrong when I'm interpreting this study, but basically these Romanian adoptees, I don't know why I'm having such a hard time saying that, but basically they took these adoptees that were institutionally deprived. So they were completely deprived of any sort of psychosocial interactions over 6 months or more. And they actually found that they had that deprivation was significantly associated and perhaps even causally linked to inattention and overactivity symptoms that they were having. So that led them to conclude that there's likely a pathway to impairment for ADHD where there's critical neurodevelopmental programming that happens at a certain period of development that if it doesn't go right, it could lead to ADHD regardless of any sort of genetic predisposition. What do you think about that?
Well, what you're getting back to is really, what we were talking about a little bit earlier. ADHD is a syndrome.
Yeah.
You may still have a few of those left in neurology where you don't know what's going on, but you describe it by the symptoms. Right. So at its face, yes, this kid has ADHD, but we know that kids who are really traumatized can also exhibit the syndrome. Kids who have an accident can exhibit the syndrome. You can have an infection. You can get a meningitis and have the syndrome. So I think what that is telling us that, really what we're talking about is epigenetics. So for your listeners, that really is the result of when genes and environments work together. And there are all sorts of things, depending, you have this gene and this type of mom or that gene and that type of mom. Different things can happen, good and bad. That's really what you're seeing here. So that, I think those kids really would reflect the 30% of ADHD that is not directly driven by genetic factors.
Got it. So there is a component of ADHD or a population of ADHD patients and people that not related to any sort of genetic predisposition or contribution, perhaps just related to environmental.
Right. So about 30% of the variance in the population is due to non-genetic issues. Lead, kids in areas where they eat paint. Lead, eating paint will give you the ADHD syndrome. So there is some of that other stuff. which again, it's really important for a clinician. The way medicine these days, the most time I have with you is probably the first time I meet you.
Right.
And I tell my students, what's it like having dinner with these folks?
Wow.
If they have dinner together, right? Do your best to understand the whole situation so you know what's impacting this person.
Sure.
Because without that consideration, you're just sending a checklist to the web.
Right.
You really can't ferret all this stuff out.
Right. Excellent point. So let's get down to what is actually happening in the brain for when you're comparing someone with ADHD versus someone that doesn't have ADHD. What is actually happening in the brain for those people with ADHD? So I came across the dopaminergic deficiency, right? When these patients are dopamine deficient, potentially. And sounds like you're going to disagree with me because you already disagreed with me based off of that genetic study that I referred to. And there's also, and you mentioned it as well already, there's clearly hyper and hypo connected circuits in the brain, and that's been noted through functional MRI imaging. So what do you think is the underlying neurobiology for ADHD?
Well, that could be a great other book. So, again, as a neurologist, I'm sure you appreciate the brain is really, really complicated.
Yeah.
And things are overdetermined and nothing is really simple.
Right.
I think, there's a lot of interest in go do a computer test or go take a brain scan and get your diagnosis that way. The reason that doesn't work is the data are all mean data. The average guy will bench press more than the average woman, but you can find a woman who's going to bench press more than the average guy, right?
Right.
We're all floating around the mean. So, but if you look at groups, samples of these individuals diagnosed with these symptoms, we see areas of the brain that underwork. Basically, the frontal lobe areas underperform; they're underperfused. We see problems with connections in terms of, again, kind of the attention signaling system versus the pay attention to the background system. Those systems intrude on each other in really inappropriate ways. Very interesting if you look at longitudinal studies of kids with and without ADHD. And actually, I have a little video of this on my desk. NIH did this. Kids who have ADHD, on average, they have myelination of the frontal lobes occurring about 3 years later than typically developing kids. Mm-hmm. And I actually have the brain images of the typical and the ADHD kids, and you can see the brain growth from the posterior up to the front. Mm-hmm. But kids with ADHD, it's 3 years later. Wow. So I'll say to parents, a lot of these kids are kind of immature, they're social, and that's exactly right. They hang out with other kids, they don't have the judgment of their peers. Their brains do grow, but it's, at least at a macro level, but it's clearly delayed. And so we're seeing all this stuff, but we don't really, nobody knows the magic solution of what exactly this is.
Yeah, I wonder if that tracks along with if the appropriate myelination of the frontal lobe in those kids follows along with their improvement in ADHD. That's probably hard to tell because they will have been diagnosed with ADHD and potentially put on medication and therapy, but what do you think?
Well, I think what you're kind of alluding to here is that many ADHD symptoms do decrease with time.
Right.
And, sometimes to the point where, in young adulthood, they're no longer impaired. Yeah. Typically, it's the hyperactive symptoms kind of get better. Mm-hmm. Now, whether this is correlated, again, with the better myelination, that hasn't been shown yet.
Yeah. Now, let's go to ADHD treatment. And it makes sense, man, the dopaminergic deficiency based off of the ADHD treatments, right? So you've got Ritalin, Adderall, modafinil, right? Most of these medications, or all these medications, increase dopamine to a certain extent, right? And I think that that's it, if you backtrack, it's like, well, these medications help for ADHD, therefore, right, there must be a dopaminergic deficiency. You're saying no.
Right.
Young grasshopper.
No, Daniel. So let's go back 25 years. And what you're saying right now is what everybody was thinking.
Right.
But then we have some neurogenergic agents come along. In other words, we have some agents that don't work on dopamine systems. They only work on norepinephrine systems. And guess what? They work too. So that kind of threw a monkey in this. I've got a great picture, though, to show this. So I don't know if you want to start talking about medicine specifically, or if you want to talk about treatment generally. We can go either way.
So we're getting into the treatment topic. Let's cover the medications, and then we'll talk about all the other kinds of treatments potentially.
Okay. Well, without a picture, maybe I can make this.
You'll send it to me, and I can put it at the bottom of the screen for people.
Okay. Yeah. All right. Well, okay.
So imagine it just like floating right here. Yeah.
Well, as I said before, a very simple way of looking at this is your brain needs to do two things. You need to pay attention to what's important, and you need to also monitor what's going on in the background. All right, so we'll call the thing that's important the signal, and we'll call the background the noise. Okay? And the problem with ADHD, again, isn't that you don't pay attention, but you don't shift properly between signal and competing signals, right? Okay, so the norepinephrine side of things, basically, if you increase norepinephrine in the brain, you increase the strength of the signals that are important. Okay. Again, in my diagram, you open calcium channel, you open potassium channels, But basically, in the prefrontal cortex, the signal, the thing that you're supposed to be paying into, gets more salient. Okay. So the norepinephrine component of these medicines increases the salience of the important thing to look at.
Do you mind describing what salience means?
Salience means just what's important.
Okay.
I'm sorry.
Okay.
Yeah. Okay. No. I know. I heard that, first time I heard that was Nora Volkow, who's like of the most brilliant people on the planet, and she runs NIDA in DC. Anyway, I had to look it up. Anyway, it increases the importance of what's important. Dopamine, on the other hand, closes those channels, and it decreases the strength of the signals that are monitoring noise. So what these medicines do is they increase the signal and they decrease the noise. Now, the medicines that only work on epinephrine only increase the signal, and they don't work as well as the stimulants, which hit both. Now, sometimes with the stimulant, you get over-focused. You turn kids into little Stepford children, which isn't actually what most parents want. Right. So that's a problem there. But if you just give a straight dopaminergic agent, it won't work. So the norepinephrine component is important.
Got it. Okay. Now, what do you think about, I've seen 3-year-olds get placed on stimulant medication, right? And there's definitely beneficial outcomes to being on ADHD medication if you have ADHD, right? And some of those include decreased depression, decreased suicidality, decreased rates of traumatic brain injury, and I can go on and on and on and on. But are there any intrinsic long-term effects of being on this medication? So I'll point out a couple of studies that I came across. So there's white matter tract changes in the brain noted with methylphenidate treatment, methylphenidate's Ritalin. And this was on a DTI study, and we don't know the exact significance of what that is, especially in an experimental imaging like DTI. But nonetheless, it was noted. There's also significant effects of studies show that there were significant effects of cumulative ADHD medication use, specifically in 2 subregions of the brain, the left hippocampus, which is involved in memory consolidation and heavily involved in memory, and then in the strata radiatum, lacuna, and a bunch of other fancy sounding words. We don't want to worry about the subregions too much. We just want to worry about, I think, is something actually happening while you're on this medication that in the long term people should be concerned about or should not be concerned about. Let me preface that by saying just because you have imaging changes, that doesn't necessarily mean it's going to translate to any sort of clinical manifestation, right? But what do you think?
Well, I think there's a lot to unpack in all the things you just kind of brought up.
Breezed over.
But earlier I was speaking about those longitudinal studies that show delays in myelination. In ADHD kids. In that study, the kids who got medicine had patterns of myelination more like typical kids. So the evidence there is that, if anything, it might promote more normal development. the big picture, and I think the most global way of looking at this, is tens of millions of people have taken these medicines. We've been using these medicines since the 1930s, and there are no major safety signals. Now, there are studies here and studies there. I mean, there's one study that suggests if you are 7 and you mostly stay on medicine for your life into your mid-20s, you may be a centimeter shorter. That may be true, but also you may have finished high school, right? Yeah. Or there are studies, there are some studies that say kids treated with stimulants as kids have problems with obesity, but it's very confounded, and we really don't know. But what is absolutely clear, to your other earlier point, is untreated ADHD is not a blessing. It more times than not really does cause difficulty. And the only other thing I want to say, though, is you mentioned the 3-year-olds. I was part of the NIH team that did the preschool ADHD study, and the medicines do work and they're safe. But to get in that study, you basically your family had to basically go through 10 weeks of parent training, 10 weeks of basically behavioral therapy attempts, and you had to be really severe. So I wouldn't put a 3-year-old on medication unless, again, there was a real safety issue. The kid was running out in the street or skydiving off of a slide, or mom had to quit her job. We really prefer to do this really when the kids are 5 or 6 years old.
Yeah. And are there any outcome studies relating to the earlier that you address ADHD, whether behavioral or medication, the better outcome they have with their ADHD down the road as an adult? There's
one actually very compelling set of studies, and my buddy Tim Willens at Mass General has done this, where they looked at, so there's a real risk for substance abuse issues with ADHD. Probably it's the allure of dopamine, as you were saying earlier. Yeah. Adult substance use problems is of the worst but most common outcomes of ADHD. Tim looked at kids, and his junior colleague, they looked at kids who started the medicines by age 9 and stayed on the medicines, started and went off, and then kids who started medicines in adolescence. The kids who started medicines as adolescents were train wrecks. They had the worst substance abuse outcomes at age 19. The kids who started and stayed on medication at age 9 actually had normal levels of substance abuse issues. So in that case, now again, maybe families who take their kid to the doctor, they're more stable, less apt to, promote substance abuse, et cetera, but all the evidence suggests only better outcomes, not impaired.
Right. Awesome. Now, you talked about substance abuse. I want to get to really quickly covering the abuse of ADHD medication. So not necessarily by someone that has ADHD, but someone that doesn't have ADHD that wants to boost their focus. A recent study found that out of 81 college students with ADHD, 62% diverted the medication to someone without a prescription. And I've also seen studies reporting up to 60% of college students misusing ADHD medication. What do you think about that?
Well, first thing, it was I suspect it was one of my friends did that study too. But it's very important to get the words right, because mostly what we're talking about is misuse, not abuse. Okay. And misuse is basically taken by someone for whom it isn't prescribed, or taken for someone for some, non-prescribed purpose. Abuse is to get high. Yeah. I mean, it's commonly used for scholastic enhancement, sometimes for sports enhancement. Interestingly, there's no data that it works in that regard. People do it. I'm sure when you went to college, you had roommates or you knew people on your floor that were staying up all night to get some paper written. And whether they took a monster drink, or 9 monster drinks or whatever, that's what this is used for.
Organic chemistry definitely drove people to misuse certain substances.
There you have it. So, that's why, we do track our prescriptions responsibly. It's getting to be the time all my high school kids who are going off to college, I always chat with them about this. There's a trust issue involved. I mean, it's not great, but it also isn't the end of the world. It doesn't keep me weak. Now, there is about 30% of use, misuse, abuse is to get high. If that's your goal, there are probably easier ways than wringing a little methylphenidate out of your Concerta tablet. Right. But there are formulations of the medicines that are less abusable in that way, or if you're really concerned with your patient, you can use a non-stimulant.
Yeah. We talked about sports performance enhancement, which is near and dear to my heart, considering I'm in the BrainSPORT program. 2013 study showed that more than 7% of male NCAA athletes reported using Ritalin or Adderall without a prescription. And that was in 2013, so I don't know what the numbers are now. And methylphenidate had an overall effect that showed improvements in recall, sustained attention, and inhibitory control, which, certainly you can extrapolate how that would benefit you athletically, right? If you can sustain your attention, if you're a race car driver, right? Drive around in circles for 4 hours, or inhibitory control, right? What do you think about that? Do you think it is a sports performance enhancing tool?
So at one time there was this conception that the medicine somehow magically in people with ADHD made them calmer. The fact is they make everybody calmer and more focused. It's just a matter of the dose. So the cognitive enhancement, the impulsivity control, that's what these medicines do.
Right.
I've seen some patients who are professional, let me just say professional racers of one sort or another, and some of them have had terrible accidents, and being on the medicine would make really good sense.
Right.
But the way the rules are, because there is a lot of cheating and a lot of concern, is there's a process. And I've actually worked with folks, with UCLA athletics. If someone has the diagnosis and they can document it and, has a prescription, you need to do that ahead of time.
Right. I
think the fact that, I said before, 5 to 10% of college-age kids probably have ADHD.
Yeah.
So maybe the 7% isn't completely out of whack. Yeah. But on the other hand, those athletes were foolish not to discuss this ahead of time. And it is unclear if that, if that really is going to help their athletic performance.
If that actually translates to performance. So let's talk about some other treatments of ADHD. Diet. I came across the few foods diet, also known as the oligoantigenic diet, which is basically when a person's diet is restricted to only few less commonly consumed foods like lamb/venison, quinoa.
Yeah, Daniel, let me just interject.
Are you going to shut it down right now?
Let me shut down here because we have more important things to talk about. One of the quandaries with this is I appreciate the distress and the concern. I'm a parent. You're a parent. I have full respect to the parents of my patients. Yeah. They're trusting us with their most important thing. But it's amazing some parents, because they're so afraid of these medicines, which are well tested and have like the highest safety records like of anything, they go to extreme lengths to do all these other sorts of things. They get brain scans and expose their kids to radiation, or they have these crazy diets. And what's very clear, and this has really been looked at well by a couple of colleagues in the UK, these non-traditional treatments that entail a lot of parental investment do really highly, they're rated very well in terms of by those people doing it. But if you look at it in blinded conditions, it's a wash. There's virtually nothing. The only dietary change that has had any impact on ADHD symptoms is omega-3, fish oil. Yeah. When your kid's a little older, you can try to shove a few fish oils down and see how well they go. But you've got to treat like 5,000 people to get one kid do better. Right. The effect size is minuscule. Meanwhile, we have treatments that we know do work. And, again, to your point earlier, your clock is ticking. Your brain's developing. You're going to be on the good track or the less good track. By denying a kid who's in second grade who needs a medication treatment for a year, you can have significant impact on that kid's self-esteem, peer relationships, awareness, study skills. So there's really a risk to not giving treatments that we know work and, following the path of some of these kind of fad treatments that really we know very well have no benefit. Well,
do you think neuromodulation with transcranial magnetic stimulation is a fad, or do you think that there's some legitimacy there?
So I've actually, I did research. My research led to FDA's very first approval of a non-medication treatment for ADHD. There are some pilot pilot studies going, and we just got another grant from NIH to look into this more. I did trigeminal nerve stimulation. There are groups looking into this, and I think that makes some good sense. Yeah. But none of this has reached the level of really saying this is established evidence. Right. And it still doesn't, in my view, outweigh the risk of not using things that we know work.
Outside of the context of medication, omega supplementation, is there anything non-pharmacological that you would recommend either to supplement medication or to do on their own? Yeah,
we have a couple of things. So actually that. Do not take what I said earlier as a eat fish. I had fish last night. It was great. Right. But you don't need to be throwing, fish pills down your kid's gullet. Yeah. The very first thing I always say is the real starting point. I talk about meds last. I start with education, right? As soon as I've assessed you or your kid, I want you to know as much of this as I do. So go learn about it. Go get good information. This is genetic. It's familial. It's your brain. It has consequences. Education is your starting point. Secondly, you need to sort of look at the environment the person is in. So, if it's a younger kid, parent management training. So I know your kid's 6 weeks old. Yeah. So in 2 years, no matter what your kid looks like, I would be advising you and his mom to take a parenting course because we know parenting skills that work and that are good and they're good for everybody. Yeah. So we use that with these kids. School accommodations. A kid starts school. A lot of times these kids, certainly if they have other learning issues, you want to address those needs. But, sitting this kid, it's the things that all kids do better on. Put the kid in the front of the room. Don't give them more homework than they need. Give them time to go pee if they need to. Give them more time on tests. Those are kind of standard accommodations. You can carry them to high school, to college. The high school kid who really has this, you can get them more time on their SAT or the ACT. Do that part of it as well. So parent training, school accommodations, accommodations also can continue into the workplace. Take care of other general health issues, certainly. Eat well, exercise, wear your seatbelt, all those things. Yeah. And then we get to medication. Now, I should mention, of late, there are a couple of new, there's a form of cognitive behavioral therapy that has been shown to be very useful in teenagers and adults, very useful. And there's also an organizational skills training program that is also proving to be very useful for these kids. And there are some new things. There are some video games. There's this thing that I work with that you wear in your sleep. It's of incremental effect, but none of this yet is able to replace what we get from using medicine.
Really quick, what about exercise? You always hear you have a really hyperactive kid. You want to make sure that they're exercising, they're running around to, in layman's terms, right? Which is how I'm thinking about it. Just like blow off a lot of that steam.
Right, and I remember the guy in my class at high school who I think failed out eventually. That was the solution. Hey, exercise is good.
Am I that guy?
Kids should. I haven't failed out yet. I'm like, you want to promote good diet. You don't have to be a diet, freak about it. You can eat chocolate once in a while, but you ought to, get out of your room, get off the Xbox, go run around, play soccer, play the cello, whatever. But those are all normal things that you want to promote. It's not going to treat your maybe marathon running will get you, or Michael Phelps is a swimmer. He's in the water all day, not bugging anybody. I mean, maybe it worked for him, but usually that's not the way out of your overactivity.
Yeah, let's hit real quick. I want to hit the ADHD predisposition to substance abuse, and I want to bring up a really cool study, interesting study that basically estimated. So currently, there's an estimate that about 23% of people with ADHD have concomitant, that people with substance abuse have concomitant ADHD. And then they said, well, the prevalence estimates might differ depending on the type of substance, which I found interesting. And I found another study that showed that people with opioid abuse, 33% of people with opioid abuse had concomitant ADHD. This was in Norway. In Austria, it was 17%. In Italy, it was 11%. But then when you looked at methamphetamine, at the methamphetamine using population, that number went up to 55%. And then in the Czech Republic, it was like 56%. I mean, which is interesting, right? Why would there be a predisposition potentially to a certain substance unless, like you said, there's that dopaminergic urge, right? Which you're going because opioids aren't really heavily dopaminergic, whereas methamphetamine is.
Well, let me push back on that a little bit. Now, methamphetamine rather. You take enough of that and you kind of develop ADHD type stuff. So
Good
this
point.
is a compound there.
Yeah, excellent point.
But we know, again, my friend Dr. Willens at Harvard and some of his colleagues, the idea that you self-select medications to treat your ADHD doesn't really pan out. It's really more a function of what's available. I've treated some Hell's Angels who, if they're not like on daily cannabis, you wouldn't want to be around them. But I think the choice of medicine is not really driven by their dopamine deficiencies. Yeah. It's just driven by the kind of ecstasy-seeking approach that they have. So we can't make too much of that.
So you don't think that ecstasy-seeking feeling and behavior is linked to ADHD at all? Like, there's no neurobiological underpinning connecting those two things?
There is. Again, I'm not saying ecstasy like the drug. I'm thinking more like novelty seeking, pleasure seeking, the ability to, the lack of an ability to delay gratification. Right. That is kind of part of ADHD. But then it's really these individuals turn to what's available to them. Got it. And then they kind of take the bad turn.
And they don't hone in on a specific drug after experimenting with many. It's just whatever's available.
That seems to be what's mostly true.
Yeah. All right. So we have like a couple of minutes left. And, certainly at BrainSPORT, we deal with a lot of concussion and brain injury, and then you have exacerbation of ADHD from that, which can really contribute to a lot of the cognitive effects and a lot of the cognitive memory complaints that people have secondary to that. Would you say that a lot of the things that we talked about in regards to treating ADHD, you could apply those in that context? Yeah,
I think actually, I know we're running out of time. A couple of things. Certainly post-concussion, you can exhibit a lot of features of ADHD. Mm-hmm. And honestly, I think, and there's I think Jeffrey Max in San Diego does a lot of this work. You might if a person post-concussion is having issues with attention or impulse control, trying a stimulant, trying an ADHD medicine probably makes really good sense. But I would say you want to be sure that ADHD occurred prior to the event if you need to really rule out that diagnosis. On the other hand, I think as again really quickly, athletes with ADHD have twice the rate of concussions of those without ADHD. Yeah. Now the good news is it doesn't seem like they take any longer to recover, but they're clearly at greater risk. Yeah. But the one other interesting fact about that is the ones who are on medicine actually do better than typical kids. Maybe to what you were describing earlier, kids with ADHD on ADHD medicines have lower rates of concussion than typical kids. So the mom who says, "Well, he's playing soccer today, he doesn't need his medicine," might think twice about that choice.
Twice about that. Yeah, excellent point. Thanks so much for joining.
Yeah,
this is great.
This is terrific.
This is awesome.
It's really nice to meet you as well.
Yeah.
Good luck with all your work.
Is there anything that you want to promote very quickly, either your research, any sort of projects that you're on, anything like that?
We are actually, so the one study I did, there's a completely non-invasive, non-risk, approved treatment for ADHD called trigeminal nerve stimulation. Basically, and we did this work here at UCLA. And basically you put it looks like a big Band-Aid on your forehead at night, and it connects to two little wires and a TENS unit, and it gives you stimulation through your forehead while you sleep. And we showed in an earlier study that about almost 60% of kids who got this treatment did as well as on the non-stimulant treatments for ADHD. We're about to launch a new study for this, along with Children's Hospital in Seattle, where we're going to be looking for kids 7 to 12 to get this treatment for 4 weeks. and we'll provide evaluations and everything you need. And if people are interested in this, they have to be off medicine.
Right.
We have the idea, and again, this is NIH funded, that there's a certain brain profile that will predict which kids do best on this treatment. And if we are successful in this study, then I think we actually will have some really good movement towards some non-medication approaches to this.
That's amazing.
Yeah, thanks you for letting
That's
me
awesome.
bring that up.
No, absolutely. Thank you so much for joining. This was a treat. And I could have kept going for another hour, but maybe you can come back and we can talk more about it.
Sure.
Yeah, sounds amazing. Thank you, everyone. This is the UCLA BrainSPORT program. If you guys have any questions, concerns, please shoot an email to the email in the video description. If you have any questions for Dr. McGough, they can email me, and I'll put you in contact with you. Sound good?
Terrific.
All right, awesome.
All right,
Thank
great.
you, everyone. Have a wonderful day.